Hello, I'm Becky Yakino. I'm the respiratory supervisor here at the hospital. We're going to talk about BiPAP and CPAP today. Just a quick overview for the acute care staff. BiPAP is what we normally would use for respiratory failure. CPAP is what we would normally use for sleep apnea. Most patients that have sleep apnea will bring in their own CPAP unit, so we won't focus on that as much. We're going to focus more on the BiPAP portions of what we would do here. If a patient has a BiPAP at home, they can bring it in. If they do, we clean it, set it up, and make sure that it's functioning for the patient. If they have one and don't bring it in, if we can find their settings, then we can set them up with our own equipment. So for patients that don't have their own that bring in or that are acute, maybe start in the ER with a CHF, respiratory failure, COPD exacerbation, we're going to want to set them up on our machines anyway because it's a little more intense for the patient, works a little bit better. We can set our FiO2s a lot easier on those. So we have two BiPAPs that we normally use. We have our BiPAP Vision and our V60s. We're going to start with the BiPAP Vision. We'll go over the settings, then I'll show you how we do some changes, and then we'll go over the V60 in the same way. We use the same mask for both machines. We have nasal masks and we have full face masks. These are our full face masks. As you can see, it has a head adapter. Our clips come around. We have our tubing that goes to the machine. This is for the flow and the oxygen. This little line is our pressure line. If this little line comes off, the machine will alarm and it will not function. So if it starts to alarm, just make sure that these lines are on. This is our exhalation port. This is a Castle port. This has to be open. If you occlude it, the patient doesn't have the ability to exhale. So it's kind of important that we leave that open. Tubing goes to the machine, runs from a filter. This makes sure that anything that's in the air doesn't go to the patient. When they exhale back through, it also will trap any particles and that type of thing, humidity and whatever. The mask itself, we size to the patient's face. So for a full mask, we want to size from the top of the bridge of the nose to just below the bottom lip. This patient is probably a small, which is what I have. It lists on the mask itself what size it is. So this is a small. We also have medium and large. When you first place it on the patient, you want to make sure that you cover both spots. Again, bridge of the nose, bottom of the lip. If the mask is too big and it goes below their chin, then it's going to cause a huge leak. We want to make sure that it fits there. Our straps go behind the patient's head. This is where it's helpful to have an extra set of hands. The clips come around. These ones click right on. And then we can adjust it with the Velcro straps for patient comfort. Now when we adjust, we want to make sure that we make it just tight enough that we don't get a big leak, and we don't want it to be too tight where it covers up or causes pressure on the patient's face. Now because our patient here has an exceptionally small head, this normally would fit a little tighter, but he doesn't have that ability because his head is so small. This little part can also adjust for patient comfort, so we can tip it out or tip it in. The main goal is to make sure that we don't have a big leak. A small leak is okay as long as the patient's oxygen levels are staying good and the pressures aren't alarming too much. So once we set it up, we usually feel around the face for any air leaks. If there is one, we'll adjust. This is the only spot, again, that you should have air coming out, so make sure that that's open. I like to keep it so it's facing out. If it's turned towards the patient, it becomes annoying to them, so just make sure that it's pointing up. Once it's all set, make sure that your machine is functioning. You'll hear it cycle. Then we'll go to our settings. Okay. So as I said, BiPAP is two pressures. We have an inspiratory pressure and an expiratory pressure that we set. Both are ordered by the physician as well as the FiO2, the oxygen content. So normal starting range is an IPAP of 8 and EPAP of 4. For patients that need extra oxygenation, we can increase the EPAP, which is like PEEP. For patients that have extra CO2, wait, no, that's not what I want to say. For patients that have increased CO2 levels, we want a higher IPAP. We want to blow off that CO2. So right now you can see we have our IPAP set at 8 and our EPAP set at 4. We have a rate that we set, and he's reading 14 right now. When I go to my parameters screen, my rate is set at 10. So I know he's doing 4 spontaneous breaths on his own. Our oxygen level right now is set at 40%. We can change that anywhere from 21 to 100%. It's very precise. So if I definitely want this patient on 40%, I set it at 40%, and that's what they're going to get. With the home units, we bleed in the oxygen at liters per minute, so it's a little more variable. That's why we like to use these for the acute patients. Our monitoring screen looks a little bit different than our parameters screen. Parameters is where we set things. Monitoring is what is normally displayed when you're looking at it. So again, IPAP 8, EPAP 4. His total rate is 13. Down here we have a tidal volume. Tidal volume is attained by the difference in pressures between the IPAP and the EPAP. So if we widen that pressure range, then we'll theoretically have a larger tidal volume. So essentially this is a non-invasive ventilator. We can actually ventilate patients to a certain degree with the BiPAP. Our minute ventilation is displayed in liters per minute. Our PIP, which is the positive inspiratory pressure, the peak inspiratory pressure, should be right around our IPAP. When it gets to that PIP of 8, it comes back down. Our pressure line shows us each breath. Our inspiratory pressure should hit to the 8, expiratory pressure should come back down to 4. Volume, you can see each breath, how big of a volume the patient is taking, which is right around the 250 mark. And then our flow, as flow is disrupted, you get the little blip. So you know everything is functioning correctly there. Modes, we can change this to a standard CPAP. We don't normally because most patients need the BiPAP, but it is a possibility to do, and respiratory would make those adjustments simply by pressing the button, activating, setting our CPAP. We have alarms set. Our alarms are set with a high pressure of 50, so if the patient coughs and achieves a high pressure of 50, it's going to alarm. If the patient becomes disconnected and doesn't reach a low pressure of 2, it will alarm. If the patient goes into apnea for 40 seconds, it will also alarm. So make sure that if your machine alarms, that you make sure you go in and check the patient, because if they have taken the mask off, obviously they aren't going to be getting any flow, any oxygen. And if they're apneic, kind of important that you go check on them at that point as well. We have alarms set for high respiratory rate and low respiratory rate. Right now this one's set at 60, and it's alarming because my hand is holding it. Our rate is set at 60, so if the patient hits a respiratory rate higher than 60, it's going to alarm. When they get to a rate below 4, it's also going to alarm, and then it'll go into an apnea alarm. Monitoring screen should always be kept where you can see it from the door. Obviously, you've seen me hit the alarm silence and the alarm reset. Alarm silence gives you about 2 minutes of quiet. So don't just go in and hit the alarm silence and do nothing. You need to make sure what the reason is being taken care of with the patient. Once you've fixed your problem, hit alarm reset. There is a volume control on here. Make sure that you do not attempt to change the volume, because if this alarm isn't heard, the patient could have some detrimental problems. So always make sure that you leave the volume alarms alone. If you notice that the volume is set too low and you can't hear it, please call respiratory and we will come and adjust that. Okay? For patients that have low blood pressure, they're a little hypotensive. This can sometimes aggravate that hypertension, or hypotension rather, so make sure that you're monitoring blood pressures for those patients and reporting to the doctor if it becomes too low. So this is the V60 BiPAP. This one's just a little bit different than the other. The theory behind it is the same, still IPAP, EPAP, FiO2. We're going to start by turning it on. Makes a lot of noise. As you can tell, the screen on the V60 is much different than the Vision was. For the V60, everything is pretty much on one screen that you need to see. So your inspiratory pressure, your expiratory pressure, rate, oxygen, our eye time and rise time, and the ramp is something that respiratory would set. Looking up here, this is the patient values. So the rate is set at 12 here, rate is set at 12 here, the patient isn't breathing above. Obviously this isn't hooked up to a real patient, so our tidal volume is only 22. We would expect it to be much higher than that for a patient. Minute volume, peak inspiratory pressure. For changes for us, we would go in, press it, make our changes. Again, respiratory makes all changes to the BiPAPs, so you don't need to worry about changing anything. Please don't. There is an alarm silence button here. Again, goes for 2 minutes. Here is your alarm reset. The informational message when the BiPAP alarms, it will say up here why it's alarming, and then it will give it down here, and we'll see if we can make it alarm. Maybe this one. Okay, so hit alarm silence. Look here, why is it alarming? It says the proximal pressure line is disconnected. We'll put it back on, hit alarm reset, and then it should function. Again, we can also do CPAP with these machines by changing our new mode. We can do pressure controlled ventilation. AVAPS is a mode that we do not use here. We can place both BiPAPs can go into a standby mode. On the Vision, there's a button that says standby. There's also one here. You press standby, and it will automatically go into a standby mode once it's not reading a patient being there. Now it goes into standby mode. What this does is if you have a patient that say you're going to give them breakfast, you can put it into standby mode, and then when it goes back onto the patient, once this goes on, it notices a patient trigger, it will automatically start, or you can simply press the restart button and everything is still the same, so you don't need to make any changes at that point. As for cleaning these machines, when the patient's discharged, respiratory will take them out of the room, wipe them down. We use the Santa Claus, everything gets wiped down. The circuit, the filter, and the mask are all single patient use and disposable. So if a patient's discharged, we throw all that in the garbage. Our circuits are only intended to be used with our mask. We cannot switch our circuit and use a patient mask. Do not send the circuit or the mask home with the patient unless respiratory has specifically sat with the patient and explained this to them. The reason being, patients' masks at home have a port built into the mask. Our circuits have the port built into them, not the mask. So if a patient at home uses their circuit and our mask, they will not be able to exhale. So that is why we do not want to really send those home with patients. I know sometimes people feel that we're helping the patient by doing some cost effectiveness for them. It's not a service if they can't breathe with their circuit and the mask on. Okay? So a quick final review. When a patient is started on a BiPAP, we need an inspiratory pressure, an expiratory pressure, and an FiO2 from the doctor. Once we have those, we can initiate therapy. If there are any changes that need to be made, the doctor does have to make those orders for us as well. So if you notice that the doctor is just giving verbal orders, please make sure that he follows them up with orders in Saurian. It's very important for us to have those as well. We do keep track on the machines with a flow sheet. These flow sheets are part of the patient's medical record. So we will do date and time, the mode that they're on, their rate, their FiO2, high pressure, low pressure settings, their oxygen saturations, comments, and then our initials. These go into the chart when the patient's discharged. We should be monitoring this every 4 hours. So if you need to know what your patient's on and you want to see when a change was made, say we went from a pressure of 8/4 to 12/4, by looking at this clipboard you can tell, so that you can put your documentation into the computer as well. If you ever have any questions or want some further education, just grab one of the respiratory therapists and we will be more than happy to go over things with you again. The main thing is, anytime there's something that you don't feel is right or you want a little more explanation, please find us. That's what we're here for. Don't just assume that things are working well and then have a problem. Okay? Thank you, guys.